Bleeding in early pregnancy. Diagnosis of pregnancy. A urine pregnancy test kit confirms the diagnosis of pregnancy through a qualitative assessment of beta human chorionic gonadotropin HCG levels. HCG is released by the syncytial trophoblast cells of the developing pregnancy. With the advent of very sensitive monoclonal antibodies to beta HCG, it is possible to detect levels as low as 25 IU per liter. When a woman in early pregnancy presents with bleeding, ultrasound detection of pregnancy with transvaginal probe can be used to confirm the location of pregnancy, as the gestational sac may be seen when the serum beta HCG levels are more than 1,500 IU per liter, corresponding to about 4 to 5 weeks of amenorrhea. Between 5 to 6 weeks of amenorrhea, a yolk sac is seen, and a fetal pole after. If fetal heart activity is seen, the fetus is at least 6 weeks of gestation. Causes of bleeding in the first trimester. For intrauterine pregnancies, causes of bleeding in early pregnancy include blighted ovum, threatened miscarriage, inevitable miscarriage, incomplete miscarriage, complete miscarriage, missed miscarriage, or gestational trophoblastic disease such as molar pregnancy, partial mole, and choriocarcinoma. Bleeding may also occur in the case of ectopic pregnancies. Ectopic pregnancies arise outside of the uterine cavity and are most commonly found in the fallopian tubes. Other sites include the interstitium of the uterus or uterine cornu, the ovary, the cervix, or within a cesarean section scar. Finally, bleeding in early pregnancy could also be due to non-pregnancy causes that coincide with the pregnancy, such as cervical polyps, cervical ectropion, cervical carcinoma, vaginal varices or infections, or hematuria. What happens during a miscarriage? In a miscarriage, there is usually bleeding into the utero-placental junction, and the placenta detaches from the uterine wall. This is followed by uterine contractions and expulsion of the gestational sac and placenta as the cervix dilates and opens. In some cases, the gestational sac does not contain an embryo. This is known as a blighted ovum or an embryonic pregnancy. Causes of miscarriages. Miscarriage may occur due to various fetal and maternal causes. More than 80% of spontaneous miscarriages occur in the first trimester, and at least half of these have an underlying chromosomal anomaly. Insulin-dependent diabetes mellitus, presence of thyroid antibodies in the absence of hypothyroidism, inherited thrombophilias and immune-mediated disorders have all proven to be associated with increased spontaneous miscarriage rates. Frequent and increased units of alcohol intake and excessive caffeine intake in the first trimester have also been associated with significantly increased miscarriage rates. Management of bleeding in early pregnancy. If a woman presents with bleeding in early pregnancy, the doctor should go through the following steps. 1. Ascertain the first day of the last normal menstrual period, LMP, and perform a speculum examination to visualize if the cervical os is open or closed and to estimate the amount of bleeding. 2. Perform a transvaginal ultrasound to confirm that the pregnancy is intrauterine, date the pregnancy, and check for fetal cardiac activity. There are 3 possible scenarios here. 1. Positive pregnancy test with bleeding and no pain. 2. Positive pregnancy test with bleeding and cramping pain. 3. Positive pregnancy test with bleeding, cramps, passage of blood and tissue. Scenario 1. Positive pregnancy test with bleeding and no pain. In the first scenario, the following diagnosis may be made. A. If the cervical os is closed, fetus is intrauterine with crown rump length, CRL, corresponding to dates, and fetal cardiac activity is present, the patient has threatened miscarriage. B. If cervical os is closed, fetus is intrauterine with crown rump length more than 7 mm and fetal cardiac activity is absent. She is most likely to be having a missed miscarriage. C. If cervical os is closed and there is an intrauterine gestational sac with no fetal pole, her dates could be wrong, or she could have blighted ovum. The patient would need a repeat scan in 7 to 10 days. D. If the cervical os is open, regardless of fetal cardiac activity, she is having an inevitable miscarriage. E. If there is no intrauterine pregnancy seen, an ectopic pregnancy must be excluded. A less common differential diagnosis is a molar pregnancy. In this instance, the endometrium is usually thickened with multiple cystic spaces. Scenario 2. Positive pregnancy test with bleeding and cramping pain. The diagnosis for pregnant patients with bleeding and cramping pain will be similar as Scenario 1, where patient experiences bleeding without pain. However, the prognosis for the pregnancy continuing is generally poor even if fetal cardiac activity is present, as the abdominal pain is usually triggered by the separation of the placenta and cervical dilation, which in the majority of patients will be followed by expulsion of the products of conception. Scenario 3. Positive pregnancy test with bleeding, cramps, passage of blood and tissue. A. When the cervical os is open and the uterus is empty, there is no intrauterine gestational sac. The endometrium thickened and an ectopic pregnancy has been excluded. The most likely diagnosis is incomplete miscarriage. B. If the cervical os is open and the uterine cavity is empty, the patient should be examined for signs of ectopic pregnancy. C. If the cervical os is closed, the bleeding and cramps have decreased drastically after passage of tissue, and transvaginal ultrasound scan shows an empty uterine cavity with a thin endometrium. This would mean a complete miscarriage has occurred. Management of miscarriages. Management of threatened miscarriage. As vaginal spotting or bleeding may occur in 20 to 25% of women in the first trimester, the treatment for threatened miscarriage is conservative. There is no effective medication for threatened miscarriage. Strenuous physical activity and coitus are discouraged. The use of exogenous progesterone supplementation in threatened miscarriage is common in many obstetric units, but there are limited evidence to recommend its routine use. A repeat ultrasound evaluation of the pregnancy in 1 or 2 weeks should be done to determine if fetal cardiac activity is still present. Do note that in all patients with an intrauterine pregnancy, a concomitant ectopic pregnancy must always be excluded. The concurrent presence of an intra- and extrauterine pregnancy is known as a heterotopic pregnancy. However, this is rare and usually occurs in women who have conceived via in vitro fertilization. Management of inevitable miscarriage. The treatment for inevitable miscarriage may be expectant or accelerated with the use of exogenous prostaglandins. If there is watery discharge and the scan reveals no fluid in the gestational sac, it will be prudent to hasten the miscarriage with prostaglandins rather than wait for the onset of pains and risk the onset of infection. If the patient has an intrauterine gestational sac with a fetal pole but has never had fetal cardiac activity demonstrated, the products of conception POC may be sent for histology to exclude a partial mole. Management of complete miscarriage. When the fetus and the placenta are delivered together, the miscarriage is usually complete. No further intervention is required if a woman suffered from a complete miscarriage. However, it is advisable to review her in 1 to 2 weeks' time to ensure that her bleeding is significantly reduced with no more pain. She can be counseled on the events that occurred and further advice given for her next pregnancy. Management of incomplete miscarriage. In an incomplete miscarriage, either the whole or part of the placenta and gestational sac is undelivered. Speculum or digital examination will reveal bleeding from the opened cervical os and sometimes tissue in the genital tract. The placenta may be at the cervical os, which will cause severe pain as the cervix is distended. The placental tissue will be seen on speculum examination, and removal of the placental tissue with sponge forceps will bring instant relief to the patient. If the patient is stable, expectant therapy is a possible option. Medical management with prostaglandins, example misoprostol or surgical evacuation of the uterus, are other options. Evacuation of the uterus is recommended if the bleeding is heavy or if there is infected products of conception, POC. If infection is suspected, evacuation should be carried out after at least 1 dose of intravenous broad-spectrum antibiotics, followed by continued antibiotic cover. The POC should be sent for culture. Management of missed miscarriage. Missed miscarriage occurs when the embryo fails to develop and dies in utero. No miscarriage occurs and POC is retained for many days or weeks until the woman has her next ultrasound scan. Many women with missed miscarriage will spontaneously miscarry, although some women prefer an evacuation of the uterus. Uterine evacuation may be performed medically with the use of prostaglandins such as misoprostol or surgically with the use of vacuum aspiration. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.